or so today's meeting we have an expert, Dr. Pramodini Swai, and this is the first one of the 6 modules, and gradually we are going to the different organs, like we will go to uterus, looking at myometrium, at endometrium, then we look at ovaries and at nexa. So this is how we are proceeding, and our final part, the last part, is Dr. Indira Palo will be talking about writing a gynecological report, how to make a very, very informative, whatever we are saying, how to write that report so that another person will easily understand, because we are talking of the same language, So how to put all that in a very uniform language. So this is Dr. Indira Palo will conclude the whole series of our education, and then if time permits, I think Shyama madam has some 3 or 4 more to add on. So we will see how it goes about, and I think let us now hear from Dr. Pramodini about today's topic, the basic how to conduct a basic gynecological ultrasound, and I request Dr. Shyama madam to introduce her.
Yes, I think all of us have listened to previous 2 talks by Pramodini madam, and how she presents everything so clearly, being grounded by our super expert Hasmukh sir. And Pramodini, as I said, she is almost a self-made expert in not only ultrasound but in other aspects of our profession. And she the best part of it is, despite being a private practitioner, she has offered herself to become one of the on-site trainers. She will go down to the Kendrapada district, to the headquarters, as well as to the FRUs quarterly, which is now which is the next set of work that we are all now ready to start. Almost 32 willing and happy on-site trainers we have identified. We have enlisted them. We have shared this list with the directorate as well as with MD NHM. And next phase is on-site training, and I'm really, right from the beginning, she offered herself to be one of the on-site trainers. And so Pramodini should now again start a new aspect of our ultrasound training, which is related to purely gynecological ultrasound. And okay, Pramodini, you can start.
Madam, I have started screen sharing already.
Yes, we can see your screen.
Yes.
You can start.
Madam, I am audible?
Yes, you are audible.
Respected Dr. Shyama madam and Hasmukh Lal sir and my gynae colleagues. Today our topic is basic gynecological ultrasound. Here our learning objective is to do ultrasound in a systematic method. So in trans-abdominal scan and trans-vaginal scans. Then what will be the key questions? How do you perform a thorough and systematic gynecological ultrasound examination? Then when should you perform a trans-abdominal, and when should you perform a trans-abdominal ultrasound, trans-vaginal ultrasound? Then what is the correct scanning technique to see each of the basics of gynec USG, like uterus, myometrium, cervix, ovary, POD, and fallopian tube. Then we should know how to use trans-abdominal probe, trans-vaginal probe, and the importance of probe orientation, and always we should do it in a systematic manner so that accurately we can find what is normal and what is abnormal in gynae USG. So this picture, as we are studying from our MBBS days, this is normal pelvic anatomy. We all are very familiar with this picture from our first MBBS days. And we have to remember that gynae ultrasound examination technique is a systematic one, and we all follow the same procedure throughout the world. Then regarding trans-abdominal scan. Trans-abdominal scan is a low frequency scan, so resolution is little bit poor, but good overview can be obtained. We can see whole of the abdomen, and for this full bladder is required. Then vaginal scan, this is high frequency scan, so resolution is super, but overview is poor. Whole of the abdomen we can see, and empty bladder transvaginal scan can be performed. Then primarily what we all are doing. First, we do trans-abdominal scan in a full bladder and have an overview of the whole of the abdomen. Then find out any abnormality is there. Then as a supplementary thing, we do the transvaginal scan so that we see the areas clearly in a very good resolution. Starting with trans-abdominal scan, we place here our probe longitudinally over the lower part of the abdomen. In longitudinal scan, while doing trans-abdominally, we get this type of picture. So fundus of the uterus usually remains towards patient's head, and cervix and vagina remain towards patient's feet. So this is fundus, this is endometrium, this is cervix, and here also we get to see the vagina, which is a line because anterior posterior vaginal wall gets opposed and the air between it casts a linear shadow. Vagina also can be seen while doing trans-abdominal scan if the bladder is full. This is how we put the probe and what picture we get on the screen. Then we move the trans-abdominal probe towards right. Then it is transverse diameter of the uterus or transverse view of the uterus we get. Here, patient's right side is seen on the left of the screen. We have to orient ourselves very much. Patient's right side is towards left of the screen and patient's left side is towards right of the screen. This is how we put our probe over abdomen and what picture we get in the transverse scan of the uterus. Then coming to transvaginal probe. How to introduce a transvaginal probe? Transvaginal probe, there is a, first we put some jelly over the probe, then put the condom, then again apply some jelly for smooth introduction into the vagina. And we should remember it should not be painful. And when we introduce the probe into the vagina, all these structures, uterus, ovary, cervix, POD, that will be visible one after other while moving the transvaginal probe. Then vaginal examination, transvaginal, while using transvaginal probe, on screen, we can get footprint towards the upper part of the screen or footprint below the screen. Actually, most of us are acquainted with the footprint on the upper part of the screen. Some people do while footprint is below the screen. So, where the footprint is towards upper part, the right side, same as in trans-abdominal scan, patient's right is seen on the left of the screen and patient's left is seen on the right of the screen. Then this is the probe. Always an indicator is there above the probe, that is anterior side, and opposite one is posterior side. And we have to introduce the probe keeping the mark anteriorly. Then while introducing the probe, gradually, first we'll have to find the fundus of the uterus. Then while withdrawing slightly, we can trace the cervix. And for ovary, keeping the probe in same position, we have to just move towards right to see the right ovary and towards left to see the left ovary. Then we can slightly rotate the probe to get the transverse view of the uterus. In this picture, vagina is in between and the cystic structure is bladder, and behind the vagina is rectum. In this picture, this is uterus and this is cervix. Always rule is find out the fundus of the
Hello,
uterus.
Pramodini.
Then
Why don't you use
again,
your mouse to? Why don't you use the mouse to show the spot? Can you not use your mouse?
madam एटी टच कले देखि पारुचंती मु टच करूची स्क्रीन टा मार्क तो होची देखि पारुचंती हां ठीक अछि ताले मु एटारे टच करिकि करूची फर्स्ट वी हैव टू फाइंड आउट द fundus of the uterus, endometrial thickness, then we gradually withdraw to find the cervix. Here we have to take the cervical length. First locate external os here, then from external os to internal os is our cervical length. So rule is always first find out the uterus, fundus, endometrial thickness, and from endometrium you gradually follow it towards the endocervical canal and get the cervix, and then there take measurement of the cervical length. This picture shows full of the uterus from fundus to cervix, and this is the external os. This is internal os. Then how we will measure the uterus? Measurement of the uterus can be taken in a straight line. If the uterus is straight, then from fundus to the external os, in one measurement you get the total length of the uterus. But that is not always the picture. If the cervix or uterus is bent, body of the uterus is bent upon the cervix, either anteflexed or retroflexed, then you can take 3 measurements as shown in this picture and add all the 3 to get the total length of the uterus. And in this way, you get anterior posterior measurement. Then move the probe, try to bring the transverse scan of the uterus and take the transverse measurement of the uterus. And it should be taken at the level where endometrial thickness is at its maximum width. Remember, transverse measurement is taken where endometrium is maximally thick.
I think Hasmukh sir, this answers your query regarding the question number 5.
This is the normal picture of the uterus in transverse scan. This is longitudinal scan. This is transverse scan. In this picture, we take transverse measurement from here to here. Then we have to be familiar with all these terms: anteverted, retroverted, anteflexed, retroflexed. A version is a term it is in relation between vagina and cervix. So when cervix is bent anteriorly upon vagina, that is anteverted. When cervix is bent posteriorly on vagina, that is retroverted. And flexion is a term body of the uterus bent upon the cervix. So when body of uterus is bent anteriorly upon the cervix, it is anteflexed. When body of uterus is bent posteriorly upon cervix, it is retroflexed. So this is the picture. This is anteverted uterus. This is the picture, and somehow you have to also imagine yourselves. whether it is anteverted or retroverted. First locate the bladder, then cervix, then endometrial thickness, then imagine what is its position: anteverted, retroverted, anteflexed, and retroflexed. This is retroverted uterus. This is anteflexed uterus shown schematically. This is retroflexed uterus. So, body of the uterus here is bent posteriorly upon the cervix. Then coming to cervix, already I have told how to take cervical length. Then we will come to the next part, myometrium. After taking the measurement of the uterus, we have to go one by one. First, we will come to myometrium. Here, we have to recognize what is the typical ultrasound appearance of normal myometrium and what abnormalities in the myometrium we can encounter during our examination. The picture showing normal myometrium. This is myometrium, this is endometrium. So what pathology we commonly encounter? Commonly we encounter fibroids and adenomyosis. Rarely we see calcification and enhanced myometrial vascularity. So in three things we have to remember. What is its echogenicity, shadowing, and vascularity. So now we will see each of these one by one. Echogenicity. All these pictures show echogenicity, different types of echogenicity. This picture, first picture shows it is hypoechoic. This is isoechoic. Isoechoic means in relation to myometrium. Its echogenicity is similar to myometrium, then it is called isoechoic. When it is less echogenic than myometrium, it is hypoechoic. When it is hyper-echogenic than myometrium, we have to describe that lesion as hyperechoic. And in this picture, sometimes mixed echogenic structures or space-occupying lesions we see. Here, some mixed echogenic lesions we see here. Also here, some cystic with solid lesions we are seeing. So this is, we have to report here this as mixed echogenic space occupying lesion. Then shadowing. We have to remember that all the fibrous tissue casts some shadows. So this is the representation how a fibrous tissue, this is a fibroid, how it casts shadow, can separate shadows with casting. In this picture, this is a fibroid and this is casting shadows. In this picture, this is the fibroid and this is casting the acoustic shadows posteriorly. So to diagnose fibroid, this shadowing also we have to see. Then vascularity. It is the normal vasculature of the myometrium. This red one is the arcuate artery. It is running parallel to the myometrium and perpendicularly radial arteries emerge from the arcuate artery and supply to myometrium. This is the normal myometrial flow. And in transverse section, the picture will be like this. Arcuate artery will be at circularly seen at the periphery and radial artery will be seen perpendicularly coming from arcuate artery towards myometrium. In screen, when you apply Doppler, you will find this type of picture. These are arcuate arteries. This is running parallel to the myometrium, and in this picture, radial arteries found from arcuate artery towards invading towards myometrium. Vascularity of the lesion. Two types of vascularity we will see while applying color. One is pharyngeal or pericapsular flow that is seen in fibroid. This is pericapsular flow, and while applying color on the screen, we are seeing pericapsular flow. And this is intralesional flow. Lesion, inside the lesion, you will find some flow when you apply color Doppler. So two types of flow you can see. One is circumferential or pericapsular flow, intralesional flow. In fibroid, you see pericapsular flow is there. Next, coming to, we will also commonly encounter adenomyosis inside myometrium. As we already know, adenomyosis means endometrium invades myometrium and menstruate there in monthly basis. So creating some altered blood inside the myometrium that appears cystic in nature. So what we will get in adenomyosis? In adenomyosis, there is uterus is global, either asymmetrically enlarged or globally enlarged, and we see fan separated shadowing, like shown in this picture, fan separated shadowing. From all of the uterus, it is coming fan separated posterior shadowing, we will see. Then myometrial cyst, small tiny cysts inside myometrium. Then endomyometrial junction. This is endomyometrial junction. This is there is a clear-cut line endometrium and myometrium, but this line is lost, either broken down or get as where in adenomyosis, endometrium invades into myometrium. There we see endomyometrial junction is broken down at some point. So all these are features of adenomyosis. Asymmetrically enlarged uterus, fan separated shadowing, myometrial cysts, and poorly defined endomyometrial junction. This picture showing fan separated shadowing of a adenomyomatic uterus. This is also known as rain in forest sign, but in screen we will see these fan separated shadows.
It is also called Venetian blind.
Yes,
Venetian.
then in adenomyotic uterus, these are the small cysts. We are seeing the myometrial small cysts are found, and in this picture, endomyometrial junction is poorly defined, and we are seeing my endometrium is invading into myometrium at some places. Then to have an idea, here endometrium myometrial junction is regular. So see how in the screen, how you will get the picture. You are getting typical trilaminar pattern of the endometrium, and it is clearly separated from the myometrium. When the endomyometrial junction is irregular, we find this type of picture. And when it is interrupted, on the screen, we also get sometimes the line is broken down and endometrium is invading myometrium there. Then relatively rare myometrial pathologies which we may come across, that is myometrial calcification and enhanced myometrial vascularity. Myometrial calcification which are seen, it is usually along the line of the arcuate artery. All the calcified source usually seen along the line of the arcuate artery that is parallel to the myometrium. In this picture, we are seeing the calcification, and it is a common finding in menopausal uterus. It is not abnormal. It is a common finding in menopausal uterus. Then regarding vascularity, first, what we are seeing in our day-to-day life, sometimes in RPOC, the products are supplied with small feeding vessels from the myometrium. There we see the RPOC is with extra vascularity can be seen. Next, another thing is enhanced myometrial vascularity. This is arteriovenous malformation seen inside the myometrium sometimes. This looks very hypervascular and the vascularity in a very bizarre manner. That is enhanced myometrial vascularity. So, summarizing again, what we are seeing in the myometrium, we are first seeing the uterus, then take the measurement of the uterus, both anterior, posterior, total length, anterior, posterior, and transverse diameter. Then see the symmetry of the myometrium walls. Then see if there is any lesions or not, echogenicity of the uterus. Then we have to define each and every lesions, like their count, where they were situated, whether they are casting shadows or not. Then vascularity, how much vascular is the lesion. We have to report on these points only. Anything abnormal, we are not certain about the diagnosis, then we can refer the patient for a specialist opinion. Then we will come to cervix. In cervix, we may encounter three things: Nabathian follicles, cervical polyp, and cancer. Nabathian follicles, as theoretically we know, it is a squamous filled mucus, squamous epithelium lining with mucus filled small cysts. Only all these pictures show different types of Nabathian follicles. All are Nabathian follicles. Only thing we have to remember, this fluid is anechoic. Nabathian cystic fluid is anechoic and it is avascular. When we apply color Doppler, these cysts don't take any color. So this is the diagnostic of Nabathian follicles. Then sometimes we encounter cervical polyps. These cervical polyps may be circumscribed or pedunculated and or hypo or hyper-echogenic. We have to see. Then some stalk is seen. When we apply color, a feeding vessel can be seen from the myometrium or endometrium up to the polyp in this way. So if feeding vessels, then it is an endometrial polyp just hanging into the endocervical canal. So when we encounter polyp, we have to apply color so that we can know from where it is coming and how large is the feeding vessel here. Then cervical cancer. When we encounter a heterogeneous mass means mixed echogenic in appearance with increased vascularity, and this vascularity will be in a very bizarre manner. Then we have to refer the patient for further investigation. Then coming to endometrium. This is endometrium. In endometrium, while starting the gynecological examination, we should always ask the LMP and keep it in mind so that we can correlate the findings of the endometrium and ovary in relation to the menstrual cycle. As we know, the endometrial findings differ throughout the menstrual cycle, and also endometrium of premenopausal and postmenopausal women are also different. This picture shows changes in the endometrium in different phases of the menstrual cycle. First picture shows the endometrium shortly after menstruation. So mostly it is a line, only a single line just after menstruation. As proliferative phase advances, the endometrium typically acquires the typical trilaminar pattern. So third one is the proliferative phase just before ovulation, and fourth one is the secretory phase. The trilaminar pattern is lost and endometrium become hyperechoic. Sir?
ଶୁଣନ୍ତୁ ଟିକେ ଆପଣ ଏଇଟା ଟିକେ briefly you skip because these are the topics for our other specialists in detail. So don't tell all these slides in detail. Just tell them that why we are examining in a basic scan, because these are the pathologies ultimately we have to rule out, because lot of chapters are given to Dr. Ranjana, and no, not lot, but some of the chapters, these topics belong to her actually. So this is your slide. You can say something here about this way. This
Sir,
slide is your changes during menstrual
Changes-
cycle. This is your slide.
this slide, in this slide, we have to correlate changes during menstrual cycle in endometrium and simultaneously in ovary. Just shortly after menstruation, endometrium is a thin line and antral follicles are small antral follicles we see in the ovary. As proliferative phase advances, endometrium acquires its trilaminar pattern and a dominant follicle gradually develops.
Actually, the topic today was just basic gynae
Basic.
scan.
Yeah,
Okay,
basic.
don't go into too many details because these visuals
just
have not been included in the questions also.
And this is the secretory. Fourth one is the secretory phase where the dominant follicle already collapsed. Then how to measure endometrial thickness? We have to remember that we take endometrial thickness at its maximum width, be it longitudinal scan, be it transverse scan. Its maximum width we take endometrial thickness. But when some fluid is there in the endometrial cavity, how to take the
again this is Dr. Ranjana's slide. I think just skip it. ଆପଣ ଏଗୁଡାକ ଟିକେ skip କରନ୍ତୁ. Just show for example that these are the things you have to rule out. Yeah. Don't tell in detail.
Sir, she has ovarian structure also. That also she has to speak.
No, I think then just say about normal ovaries. That's all. Pathology कहंतु नहीं, abnormal कहंतु नहीं, abnormal टा कहंतु नहीं आपण.
I think you should stick to what is normal.
But sir, I am skipping. Already I have told
This is
one.
okay. Menopausal, triple air and pre-secretory. That's all.
Then in post-menopausal women, endometrial thickness is usually 2 to 3 millimeter. And
Yes,
we-
Pramodini, you had put one question on this, which I struck out because this was not in the slides that initially it was shared for the first session. Okay, so I said it is not reflected in your talk, so why should it? I didn't know that you are including this also.
endometrium in post-menopausal women is
Everybody
usually
should know this.
3 millimeter. But when it is more than 5 millimeter, though it is not necessarily pathological, but it should be investigated further in a post-menopausal woman. Then describing the endometrium, this is hypoechoic, this is isoechoic, and this is hyperechogenic. Just see the picture and then have an idea. Then coming to ovaries. While we introduce the transvaginal probe, just move the probe towards right to get the right ovary and to the left towards the left ovary, and just follow the fundus also. When you find problem in finding one ovary, then just follow the fundus. Then taking the measurement of the ovary, we usually take the measurement of the ovary in 3 planes and machine automatically calculates its volume. This is how the right ovary is seen on the left side of the screen, left ovary is seen on the right side of the screen. Then coming to the color score.
No, এটা skip କରନ୍ତୁ. এটা skip କରନ୍ତୁ. Yeah, don't tell any advanced one. Yeah, these are iota things actually, so they will speak. Don't worry.
Sir, power Doppler.
এটা ছাড়ি দিও. No. ଏବେ କରନ୍ତୁ ନି ମାନେ
Bit by bit we have to give. No, they'll get confused if we keep speak too much. Okay, just basic thing ago. Tapare from near to far is the rule for educating.
color टा कहंतु नहीं. जाओ.
Sir, power Doppler भी को छाड़ी दउची.
नहीं
Next step थिबो pulse repetition frequency भी छाडुची.
Power is completely Doppler session is going to be taken separately.
Sir, एटा के मैडम एटा किंतु सबुठी तो apply
Yeah,
No,
but then
able to don't
अच्छा
speak about this now. They just simply have to say how to
Yeah,
view the
this is-
uterus abdominally
yeah.
and then vaginally.
This
And
is your slide. This is your slide. This is your slide. Yeah.
Then we should know the what is the normal ovarian findings in premenopausal and postmenopausal women and ovary throughout the menstrual cycle. So ovarian volume, it is usually up to 10 ml in premenopausal women and about PCOD. What are the features you find in PCOD? Number of follicles is within 10 in a normal ovary, and according to Rotterdam's criteria, when the follicle number is more than 12 and it is arranged peripheral and volume is more than 10 ml. And another point is increased stroma is also seen inside the ovary, increased stroma. Then in postmenopausal women, volume is 1 ml. This is again repetition of the same slide. This is the endometrium and ovary in different phases of the menstrual cycle. Then coming to POD. Fluids in the POD found in two conditions normally. As we know, in the post-ovulatory phase, some fluid in the POD is normal and some fluid in the POD is normally seen also in menopausal women. Then we have to find out how a corpus luteum is seen. After ovulation, the dominant follicle changes into corpus luteum. So just have a look. All these 7 are features of the corpus luteum. This is just number 1 slide. This is just the dominant follicles collapsed. Second slide, the ragged wall of the corpus luteum. Third slide, the cyst is filled with altered blood. Fourth slide, this fluid with low echogenic debris inside it. Fifth slide, some fibrin deposits are there, so thin straight lines are seen inside the cysts. Then it is mixed echogenic appearance. Then last slide, it is one clot. So you try to push the clot using your transvaginal probe.
Pramodini, we are going beyond the scope of this talk.
I think this is her talk. Yeah, this slide belongs to her.
Corpus luteum is normally seen in every cycle. They will see corpus luteum.
Yes,
So,
yes.
so you try to push this clot. This will dislodge, move towards upwards, and again it will settle to the bottom. This is also one of the findings in corpus luteum. So you have an idea how a normal corpus luteum can be seen, and in earlier part of the ovulation, means 18th, 17th day, the corpus luteum cyst will take color. Then ovarian findings, what we find? Normal ovarian.
No.
Sir, I am not going to describe this. These people,
Just
they will see either it is a normal ovary, functional cysts, benign tumors, or borderline tumors. All these findings you may encounter. Then coming to follicular cysts or simple cysts. Simple cysts are thin cysts and containing clear fluid, and this will not take color. Then corpus luteum cysts, again repetitions. The second slide, fluid with a label, that is also corpus luteum cysts. Then corpus luteum cysts take color and it will vanish after 3 to 4 weeks. Then fluids in the, when there is fluid in POD, fallopian tube sometimes seen. This is the fimbrial end. We are seeing the fimbrial end of the fallopian tube, but normally fallopian tubes is not seen. Till now, what we have discussed is what we see on the screen, but vaginal ultrasound is a dynamic examination, means we can feel something. What do we feel? We can feel the mobility of the organs, fixity of the uterus or ovaries we can feel, and tenderness at some points we can feel. That's why vaginal examination is also a dynamic, interactive examination. In addition to seeing something in the screen, also we can feel the fixity or adhesion and tenderness of the organs. So after all these discussions, we should be able to know what is the changes seen in different phases of the menstrual cycle in a pre-menopausal woman, and what will be the pictures of the uterus, ovary, endometrium in a pre-menopausal and post-menopausal woman. So basics is we have to orient ourselves to the image, then optimize our image, and you should go in a systematic manner. First, trans-abdominal scan in a full bladder, have a good overview, have some idea about the findings or any abnormalities. To supplement it, we use transvaginal scan, where under a very good resolution, we see all the normal structures or any abnormal structures we encounter. We again reconfirm it by transvaginal ultrasound. This is all of the basics of the ultrasound. Now, gynec basic USG.
And from
Thank
here you move on by practicing reading books. Tell that.
From here, you move on by practicing reading books and also participating in webinars. Thank you.
Thank you. Thank you so much. Yeah, excellent talk. And I would like to add on this is if you, Dr. Pramodini, can you remove your sharing? Can you remove that actually?
Stop sharing. Just stop sharing. Just click stop sharing.
Yes,
So point is, let us say what is. Let me find out. Let me find out where I am, and just a moment. How I do my gynec scan? This is I want to share with you, right? So how I do my scan, but I think I have to take out my presentation.
As Snoop sir is waiting, can anybody say why do we have a full bladder for an abdominal scan? These basic things should be known, because if you don't have a full bladder, you will have the omentum and intestines coming down in front of the uterus, which will block the ultrasound waves. And full bladder means it has to be beyond the fundus of the uterus. So it should be just beyond the fundus of the uterus, but it should not be overfull also. If the bladder is overfull, then the uterus gets distanced from the transducer, and the picture is also not very clear. So how much the bladder should be full also you should be able to decide. Because half full means it will go right up to midpoint of the uterus. You won't be able to see the full uterus. So the bladder should be full enough to go just beyond the fundus of the uterus. Not overfull, not underfull also.
Okay. So I think this is what I would like to add on something. These are how it is. This is Dr. Pramodini has already told about what are the typical ultrasound appearances, and these are the key questions. And I also would like to add something like, how do I recognize a correctly positioned intrauterine device? Because this is an everyday affair, and this is a basic talk. You know, this is a basic thing. I would like to add on this also in my subsequent slides. Can you hear me, madam?
Yes, I can.
Hello.
Yes, sir.
I think foreign bodies inside the uterus and other things should be dealt in another session.
No,
Yes,
madam,
sir.
this is a very three to four slide, but this is a basic talk. Lil Valentin talked of this basic examination, because this is if you want to because it is not, it may not be there, I don't know, but anyhow I will skip. But let me tell you how I do my scan. So whether your footprint is up or whether your footprint is down, always see that the patient's right should be on the left of screen. So there are two other alternatives which I will show you, which we do not like to use. Now in this is a picture, is a mid-sagittal view of the uterus, sagittal section. I will describe. These are the, I think Dr. Pramodini said this echogenic line is because of the mucous membrane anterior and posterior, they collapse, and therefore it creates a echogenic shadow. Now,
And the
look
air,
at this picture.
air trapped
This is
in the vagina gives a white line.
white
The
line.
air that is
And-
trapped.
Right.
Yes, madam.
Right from the uterus to the vagina, there is a trapped air, gives the white
Yeah.
color.
And this is the ureter. Look. Sometimes if you are doing an examination, you will see a jet of urine coming this way. So what I do when I do is I will put the probe into the I will place it in the introitus. I will show you. See, this one is to be used. This is how I use, and this is a good one because again here the patient's right will be to the left of the screen. So these two are usable, and these are the confusing ones, the black. These are the confusing. So don't try to use these two. I think when we do a on-site training, we may show you if you have some cases, and if we are allowed to do that. So this is one thing I had to see. And again, Dr. Shyama madam has already told that why these are again the basic physics principle that in abdominal scan, what happens, because we are using a low frequency, the resolution will be poor because our depth will increase, but resolution is lost. There is a compromise. And good overview is why it is, because sometimes what will happen if you are doing only a transvaginal scan, and transvaginal scan has a depth of only 10 centimeters. It can't go beyond that. We can't look at the abdomen. So whatever masses or any pathology is present in the abdomen, we will miss.
Particularly large fibroids, you will not be able to reach out.
And also
And
sometimes
if the ovaries have been stretched up, you cannot reach out for the ovaries also.
Right.
Sometimes you may miss ectopics also.
Yeah, and then I think why there is a full bladder is already told, and we can scan the whole abdomen by abdominal scan. This is an advantage. And vaginal we are using high frequency, so depth is not very much. You can't go beyond anything about 10 centimeters. We can't see that. Now, this is a gynecological examination is a systematic examination technique. Always use the same procedure. Why? Because suppose if I'm new to the subject and I introduce the probe, what will happen? I see a ovarian cyst and I get lost with that, and I just analyze the whole cystic structure, and the patient leaves the room, and I find that okay. Arvindo Babu, apna katha take mute karantu. Arvind Nepal, please mute yourself. So what happens in a systematic examination, as I said, I will show you coming to that slide. Look, what I will do is this is the footprint is up, right? I have put the probe in the introitus. So this is the vagina I am seeing, looking at. This is bladder. This is the ureter. Urethra. This is the urethra. See, look at the urethra. And this is the anal canal. So our examination starts right, we are introducing very, very slowly. And what is happening, we will see that the vagina is completely free. It is freely moving. It is freely moving and not adherent either to the rectum nor to the urinary bladder. Because if there is some adhesion in case of endometriosis or some pathology, then there is a pathology already we have detected right here. And this is always my technique. Always you will see the bladder to the left of the screen, and the rectum will always be to the right of the screen. This is what I come to the next point is when I reach higher, the first structure I see is the cervix. You know, this is my technique. This is my technique. What I do is I am coming, introducing the probe slowly and coming to the looking at the cervix. This is the Nabothian cyst. It is a normal finding. And I can see this is the vagina. There is some kind of some fluid here. I can see the contour of the cervix here. I can rule out if there is any mass or any pathology, any other pathology. And looking at the canal, the cervical canal. And what I do is I will tilt my probe a little bit and see that this cervical canal, this echogenic line, it is going toward the, look, here it has come. I have followed right, I am following the cervix. I am coming from here, this cervical canal is mixing with the endometrial thickness. So this is, I think this is the perfect mid-sagittal view. I will know that I am completely in a perfectly midline. This is one thing I see. I will see that the uterus has a smooth outline. I see that the myometrium has a homogeneous structure, ecotexture, and there is a clearly, distinctly, I can see a line which separates the endometrium and the myometrium. So this junction is very important. And I always do what I do is I will go below the cervix. From below the cervix, I will go to the top of the fundus by my sliding movement. You know, I will show you which kind of movement I do, and by so that any pathology above the fundus also there may be, you know, pedunculated fibroid or something. So we will always find something if there is something abnormal. And if we are not able to reach it out, I take a supplementary abdominal scan. So this is one thing I wanted to share. And endometrial thickness is, as she has already said, that it is the maximum thickness it is to be measured. And this is the diagram, how the whole AP diameter has been measured and how the endometrium has been measured. And transversely, again, you see the thickest part, the widest part of the uterus has been measured, widest. Ovaries are not included. Ovaries are not included, right? So again, what I do, I have finished now the uterus. So what I do is I go to the corner of the, you know, I go to the fornices, you know, fornix. I just push my probe here, and here at the corner, I know that the fallopian tube starts. Normal fallopian tube, Dr. Pramodini has already told us it cannot be seen unless there is a pathology. We can see in case of either there is some fluid or in case of some pathology. So this is, I follow the tube to look at the ovary, because if I follow this to the lateral wall, I will reach the ovaries. See, this is, I have just angulated my probe, and this is the longitudinal one. I have got this. Again, this is the, I have manipulated the my probe to 90 degrees to take these two measurements. So all the three measurements will give me the volume. Yeah,
two orthogonal planes have to be seen, and you have to divide the image in the beam mode in two parts, isn't it? For measuring the ovary, you have to have
in a dual screen, And yes. This is again, I go to the next part, the other side of the ovary, and this is how it has been measured. And this is the pouch of Douglas. This is very common in case of
During ovulation.
fertile woman. We may see sometime during her
Free
menstrual
fluid in
cycle.
pouch.
Yeah. So
Here,
this is one thing
a point, Hasmukh sir,
madam.
people should know that if you can't find the ovaries, you can put color with high PRF, not low PRF. Then you will
Right.
see the internal iliac vessel.
Iliac vessel, medial to that, we find the ovary.
Just beyond
Right,
the ovaries, lateral to the ovaries will be the same side
Vessels.
iliac vessel. So that will
Right.
guide you to the ovary. And
Right.
don't put low PRF. It should be at least more than 1.5 or 1.3 or 1. It can be 2 or 2.5. So that otherwise, if you put low PRF, the whole screen will be full of color. That will be dealt with in a session on Dopplers in obstetrics as well as gynae, which we all, I think, it has to be included after the
Right.
gynae course is over.
Right. Okay. Now again, you see here, this one she has already shown that when there is a fluid, you can have a look at the fallopian tube. Again, during transvaginal scan, what I do is I always look at this. There is some kind of a little bit of fluid will always be there, even if the lady has gone for the washroom and she comes back for a pelvic examination to some degree. So what I do is I look for any masses, any adhesions, or any pathology between the uterus and the bladder. This is how I look at. And she has told already this particular thing, that adhesions and site-specific tenderness. And that is why it is very important that we push the probe. We push the probe to elicit tenderness. Then abdominal scan. Now this is, madam has already told about full bladder. And we follow the same systematic procedure. As I told you that first I put it in the introitus, slowly I introduce, look at the cervix, follow it to the up to fundus. After completion of the uterus, I just go to the ovaries and look at the side walls and see if there is any extra ovarian mass or any pathology. So I go beyond the ovaries. So I not only confine to the ovaries, but any extra ovarian pathology also. Now, here, this is very important. Now, abdominal scan, what is happening? We take a sagittal. I told that what is a sagittal scan, because this line has to be a continuous one to say that, yes, I am in a perfectly sagittal plane. Now, from here, when I have to go, this is again, I have rotated my probe to 90 degrees. And how do I find the ovary? So I stay in the midline, I stay in the midline. I do not slide my probe to the left or the right, nothing. I will angulate it, I think you can't see me, but yeah. My picture is not there. So what I do is I will keep the hi. So
Dr. Purchandji, please mute yourself. Please mute.
Binod Babu karo.
Please mute yourself, Binod.
So what I do is I just keep my probe in the midline. I angulate it toward the right to look at the right ovary. So pelvic wall. I look at the pelvic wall. You can see I am looking at the ovary when I angulate, and this is the iliac vessels, as madam has already described this one, and this is on the other side. So point is, don't slide or don't move. Keep it in the midline and angulate your probe, right? So this is very, very important. Otherwise, what happens is if you slide it, you will never see ovary, and you will say, oh, I couldn't see the ovary. But you will always see the ovaries mostly medial to the internal iliac vessels. Madam has already pointed this out. Or sometimes you could take the help of the Doppler. So what, again, one thing you have to confirm that yes, this is ovary. What I do is I will again rotate my transducer to 90 degree, and I have to see the same structure in a transverse view. So I know that, yeah, this is perfect. It is a longitudinal, and this one is a transverse. So this confirm. If it is not, if you don't find this particular thing in the transverse view, possibly you are dealing with an artifact, you know. So anyway, my slide has stopped moving. Okay. So these are normal. Madam has already told this, that it will, you know, what I always ask a woman who has come for a pelvic examination, what was her last menstrual period, because then I can correlate the finding. In case of, let us say, many people are, Dr. Balram's house sent some cases of infertility. So we have to look particularly at the hormonal response, and we decide on which day of the period we are seeing her. So this is very important, and it changes throughout the menstrual cycle. So we must know the last menstrual period when we are doing, especially in a fertile woman. And this is a normal thing, is we have to look at the smooth contour, you know, you have to look at the smooth contour of the uterus. There should not be, again, there is a sliding sign. If you push it, there should not, these two structures should be moving against each other. That is called the sliding sign. If it is not moving, there is a adhesion, and we think that, okay, there is some endometriosis, might be the cause. So again, this is the changes. What will happen here? Let me elaborate a little bit. This is a thin endometrium. I already pointed out that last menstrual period. This is shortly after menstrual. There is a thin line, and we will correlate with the ovary also. The ovaries will not show any large follicles by then. All the follicles will be of similar size. There will be no dominance is not visible there. This is the proliferative phase when it thickens, and there is a three line structure. And in the later part of the proliferative phase, just before, one day before ovulation, we will see this hypoechoic zone around this three line. And why it is so? We now interpret that yes, there is some progesteronic influence already is coming here, and therefore these three lines, above the three lines, we are seeing this hypoechoic area. And as soon as there is a
zona, it is called zona vascularis.
Pellucida कहती ना, ताको कौन कहती?
Zona vascularis.
Pellucida vascularis. Okay. So, and then this particular is secret. Yeah, he's a great teacher. And as soon as the ovulation has occurred, you know, the three lines will disappear. Then it is a secretory phase. And this is the correlation, as I was showing you. This is the ovaries shortly after period, and this is 3 days before ovulation. So it will not be very big one. And just 1 day before ovulation, the follicle, it achieves something like 18, 19, 20, and then in infertility, we advise for some HCG injection also. And this is the vascularity 6 days after ovulation. This is the corpus luteum has been formed, and it is a vascular structure visible. So this follicle has collapsed, and we are seeing the corpus luteum here. And yeah, these three structures are, the lower three structures are called hemorrhagic cysts in the corpus luteum. This is a spider web appearance, you know, and this is a mixed one, and the clot has retracted. Whatever blood was there, the clot has retracted. There is a clear appearance here, and then this is the clot. I think, yeah, I think these are the, see, the size is not very important, but the echo texture of the organs, or the organs and the ovary, size may not be very important, but echo texture is very important. From judging from that, we say yes, it is normal or it is abnormal. Now, these are the Rotterdam classification. Again, it is given. And nowadays, there is a big discussion going on as to we should include, we should say PCOD when follicles are more than 25, because with the clarity of resolution the ultrasound machine has been giving now, we are seeing more number of follicles. So I think this is the topic that it will come up. We have expert people here in the group, and they will share this. Now, madam didn't want this, but these are only 3 slides anyhow. But uterus with calcification, already madam has already talked about this. And sometimes see, in postmenopausal woman, the ovary, you see, there are no follicles at all. It is completely looking hypoechoic. Sometimes we may see an ovary with a small cyst. Possibly this is an inclusion cyst, and these are not very, I mean, they don't come from the ovary actually. This is the peritoneal fold, which is there. And yeah, and how big, as I said, size doesn't matter, but the function and the appearance, the eco texture, it matters. So I think this is the final slide. And after that, you know that from here you have to move by practicing your own. You know, you should know how to do it, reading books, articles, attending more advanced ultrasound courses. So thank you so much for giving me this time. Thank you.
Yes, deliberately, the last question I have put using the IETA, IOTA, and IDEA,
Yeah.
so that you will know what you are, what you will be exposed to, and all these are important areas that we have to learn, and that's why I put the last question on these terminologies. You should know what those terminologies
I think
are.
there was a slide on this. Dr.
Yes,
Pramodini,
yes.
can you share that? The one which says the terms of IOTA, IDEA. There was a slide with you.
Yes, she omitted that, but it was there in the PPT that she shared with me. I said, let them be exposed to these terminologies now.
Yeah.
So that,
And beautiful papers are there. I think we will try to share it in the virtual group. We will show that actually. I will put it.
and another news is this year they are having clinical ultrasound in practice CUSP 2022, which comes every even years, and this time they're having it in September. I think Hashmu sir must already have registered. Yeah, so I think if any of you are interested, you can register, and it will be a good exposure also, because they have pre-conference workshops and they have 3D, 4D. If you really want to develop your ultrasound capabilities, this is the best forum, and you will have all the experts around the world coming here. And Chennai is not very far, Tamil Nadu. So I think you should register for this also. We can put it up, put up the registration forms in the group if you like.
Right.
Okay. Now, any questions from the participants? You can unmute and ask. Or shall we put the post polls now? After the post polls, each of the questions will be discussed by Hashmukh sir. Any questions from anyone? Echogenicity of the endometrium, supposing it is very much hyperechoic, you can also have it is due to endometritis. So hyperechogenicity infection can cause high echogenicity, because the gases liberated by the organisms can cause hyperechogenicity. So after an incomplete abortion or a septic abortion, if you have evacuated and we have done an ultrasound on this lady, the uterus will be normal size, but the endometrium will appear quite echogenic, and this is due to the organisms present in the due to infection, endometritis.
The
And
white
they
screen.
cause liberate gas, and gas is impervious to sound waves, and it reflects. That's why it appears echogenic. This also you must have in your mind. Particularly in septic abortion, it is diagnostic. I think it will be dealt with in the subsequent presentations.
Behind that, ecogenicity, there will be streaks of shadows. Like
Yes, Narottam wants clarification on the use of trace method.
Tracing method is available on lot of equipment these days,
yes.
and
thereby
we don't have
distance. You can put distance from one point to other, then take another distance, add it up, and then you can choose the length and use that distance. It may go beyond your uterus, but that is the exact length.
Right.
So
modern machines are all having. Just ask your application specialist, he will show you where it is. You know, जोठी आपनकर कैलिपर लिखाई छी सेटा को प्रेस करा बेलकु आपण सब पाइबे, माने ट्रेस भी पाइबे, डिस्टेंस पाइबे, वॉल्यूम पाइबे, सब पाइबे कैलिपर्स जो लिखाई छी सेठी.
Any more questions?
Can length measurement directly and by dress.
Postpone.
ठीक अछि. Sambit sir, postpone questions asjo. Pramodini, thank you very much for your presentation. You had lovely slides. No, it's okay. If she has gone beyond what she should say, it is also a teaser to those.
But she showed what are the possibilities, you know.
Later
she
on,
has just sensitized us. She has sensitized us and shown
yes.
what all you can see and why it is important. Why
Yes,
a pelvic
valid question by
scan.
Santosh Sahu, that sometimes left ovary cannot be seen. Yes, you are very right, because the bowel loop can cover the left ovary, and in that case, you can angulate the transducer a little bit more, and you can look for the iliac vessels, or you can go and confirm it by transvaginal ultrasound, or you can
either that or push with the transducer to
yes.
dispel the gas, you know.
Yes.
That is also possible. If you are pushing with push hard with your transducer and dispel all the gas which is overlying the
bowel loops.
Yeah,
bowel loops can fall over that, or you can have a bladder a little more full.
Possible, yeah. We adopt different techniques. Sometimes I tilt the patient. I say, okay, turn left, turn right.
Yes.
You know?
Yes.
So that is also one way. It's just I think you can own practice how you do it. Actually, ultimately your goal is to find it where it is.
You can put the head down a little bit, tilt the head down. Okay, start answering the poll questions, everybody. Quickly, don't leave. This is the most important part of the learning, and this is now, and just now, and a lot of people leave at this time. Please answer the poll questions. We will not be able to know if you have answered correctly or not correctly. Your own score will be only shown to you. Yes, very good. Don't leave before you answer the poll questions, and even then after that you must stay back when each of the questions are being discussed by Hasmukh sir. Please read the question properly. Question number 1 is very clear. poor resolution is true or false? If it is true, then it is not the best response. Best response is what is not true, you have to select that question. So it is very much obvious why some people have chosen poor resolution, because that is true for abdominal scan. You want to find out which is not true. So not true is the best response in this choice. So those who have put poor resolution, you have not understood the questions. Please go back and change it. You have not understood the questions. Abdominal scan ray, quota true nuhe. Abdominal scan is doesn't have has a poor resolution because it is that is true. So why are you choosing that? कौन बुझी परलो ये एटा poor resolution choose करूची काहेंगी बुझी परनो question because the frequency is much less, resolution will be poor. When the frequency is higher, then resolution will be better. In TV scan, resolution is much better because the frequency is high, and in transabdominal scan we are going to the depth, but we are not in high frequency. You can't go beyond, as Smuk sir had mentioned, not beyond 10 centimeters you cannot go. You can go in TV scan. So therefore we have high frequency over there and less depth. High frequency, good resolution. Low frequency, poor resolution. Still people have not understood why they have chosen that question 1. Can you do an abdominal scan with empty bladder? You cannot. So that is the untrue part of it. It is so obvious. Can't you choose other options? I am providing the.
Yeah, you can change it now. You can change it now.
Change
We
it,
will have
change it.
100%.
Change
You
it.
can change it. We will have 100% of the people responding right. Yeah. Yeah.
Is it untrue that you scan the abdomen in ultrasound? In abdominal ultrasound, you can go up to the liver, kidney, up you can go. To any part of the abdomen you can go. So that is true of abdominal scan. Why are you choosing? We are asking you what is untrue, what is not true. And all are true except which one is not true. That is the right answer. Please don't leave. Please answer the questions and go. Answer the question and don't go. Because if you have made a mistake, you won't know whether you've made a mistake or not. And we won't be able to know your mistake. You yourself will be able to find it. Once you have finished answering, don't leave. Each of the questions are going to be discussed. That's the most important part of today's session. You were shown the questions before you saw the PowerPoints. Then you saw the PowerPoints. Then each of the doubts were discussed. After that, you're shown a post poll which you will answer. And after that, after the post poll, You will be told which is the right answer and why.
Our next talk is examining the uterus, cervix, and endometrium is our next talk. And Dr. Ranjana Bhandari is our expert. She will be talking on that. Please do attend because she is going to be sharing in a great detail about cervix, about endometrium, and about uterus. So henceforth, most of the pathologies that occur will be discussed, and therefore please be with us in subsequent ones. And this is how it goes about. Let me elaborate once again. That Dr. Ranjana Bhandari is talking about next lecture is uterus, cervix, and endometrium. Again, she's talking about uterus and myometrium about a great detail, and also there is about ovaries and adnexa. So these are her topics, examining the ovaries and the adnexa. So these three are for Ranjana Bhandari, and we have one topic for Dr. Indra Palo. She will be talking about typical ultrasound appearances of the most common pathologies seen in the adnexa, and this will deal with the IOTA, the International Ovarian Analysis Tumor Group, and Dr. Mala
active management of third stage, management of BPH जो training है इसमें दक्षता जाइए ना.
So Dr. Mala Sibbal has confirmed to be there for Indra Palo's topic, and also about ovaries and adnexa. She may be there. Yes, there is a 95% possibility. If she is not going abroad, she will attend one of the Dr. Ranjana Bhandari's topic, which is examining the ovaries and the adnexa.
Last time
And those who would like to join a private course, there are two which Mala Sibal, there are three also. The one is Gynae Academy course, another is obstetric ultrasound and fetal medicine. Those are worth taking part. I think we can afford, and you can those who can afford and are interested in increasing your capabilities. Really very good. Murthy and Lakshmi Ravi are there in the and Vijay Balkrishnan, I think, in the ultrasound in the obstetric part, and Sonal Panchal and Mala Sibal herself, they are in the Gynae Academy part, and it's worth attending. At least Pramod and myself learned a lot. We've both done those two courses. And then
recently they have added two of new things.
Infertility.
Infertility part, they are now teaching students to do how to do research and how to write, how to publish your papers and all that.
Yes, yes.
Yeah.
So it is too much to ask from our specialists who are working so hard in the periphery. They have to do postmortems, they have to do emergencies, they have to do OPD, separate OPDs. Lot
But
of
our professors have the scope. Our professors who are in
Ma'am
teaching
also rape victim examination also we
yeah,
have
yeah,
to
yeah,
do.
yeah. Too much. So what we have given you in these two courses is quite sufficient, more than enough, and it has generated a lot of interest. Thank you very much. Now the machines which were underutilized are being utilized. Those who did not know how to hold a transducer have got the confidence now to hold the transducer. And then the beautiful part is some of you have also enrolled yourself as on-site trainers. Those who are trainees, you have enrolled yourself as on-site trainers, and for you, we will have a special TOT before you go out to the districts. That is being organized by UNICEF. So thank you very much. Those who were committed and were spirited, they have gladly included themselves in the trainer group. And one is Sasmita Das from some hospital. She was so keen, and I talked to her dean. She's also going to, I think she will be given Puri district, and she was very happy to be one of the trainers.
Thank you, madam. Thank you, madam. I am here.
Smita, I'm proud of you.
Thank you, madam.
Because
I'm
some
learning.
hospital has a lot of
I was-
footfall from not only Puri but all surrounding districts. A lot of patients come to some hospital. It's just like almost a government hospital. Very, very busy and very well organized setup is there. So Sasmita will be very useful for these people, and she can go down and to the specialist, and if she does the hand holding, and it will be a very good thing. So we went out of the way to take Sasmita. I even spoke to her dean, and on her, and that too, on her off days, she will be going out to the district.
Yes, madam. Yes.
Yes.
I'll
Good.
make my time.
Yes,
there is
we
no
will.
problem.
We'll write a letter to your dean. It's already in the pipeline to be sent, and we're really encouraged by your interest.
Sangamitra madam is
Together,
also
remember,
interested.
all of us are Team Odisha participants and trainers. We must reduce the maternal mortality in our state. Next, it is only marginally reduced from 150 to 136. So in the next SRS, we must go down absolutely. With your interest and participation, we are all in one team. Not just ultrasound, you have to use the non-pneumatic anti-shock garments, you have to use gestosis scoring, you have to look at birth companions, right from the involvement of birth companions from the antenatal OPD, when procedures are being discussed with the patient and the birth companion. So many other inputs are there, correction of anemia, recording of blood pressure in the proper manner. So a beautiful checklist is being prepared by UNICEF, and it will be given to all the trainers, so that these are the areas which will be covered. And also you specialists who are there in the FRUs, it is also a bounden duty to go down to delivery points and VHND if you can, because we are in mission mode now, definitely to reduce our maternal mortality. And I gave another proposal to the MD that 108 ambulance and drivers also should be trained in the use of non-pneumatic anti-shock garments. Supposing they pick up a PPH patient from somewhere who hasn't been given the garment, if the 108 ambulance pharmacist can wrap up this garment and bring the woman to the facility, a lot of blood loss will be saved, and the patient can be saved, and mortality will be reduced.
Very true, madam.
So that proposal also we have given, and very gladly they have taken it up. Discussed with DFW, with UNICEF, and with our superintendent. They were all discussing yesterday. And another surprise is there for all specialists. You will be given online training on perineal injuries and episiotomy by none other than the world authorities. I'm breaking this news before you. Today itself, MDNHM is requesting Professor Abdul Sultan, who has given the green top guidelines, and Professor Rani Thakkar, she's the President-elect of RCOG, and Professor N. Raja Maheshwari for teaching you the best practices in perineal injuries and episiotomy. And after that, they will give recommendations. And we are also trying our level best to bring them down to Orissa. From UK, both of them will come down. And Professor Raja Maheshwari also, she's in Chennai. And they're all the world experts. They were my mentors. And so this facility will go out to you all. And you will be, just as you're listening to Hasmukh Lal and all the trainers, you will be also in these online sessions, you'll be listening to the world authorities on perineal injuries, episiotomy, how to conduct a delivery so that you minimize the tears. Beautiful videos are there. And also they will show us the modules that can be used to teach episiotomy. So with that, our trainers also will be going down to you to show you the best practices. And one big thing is all of you are using catgut to suture episiotomies. This I've also pointed out to them so that when the world authorities recommend that you have to use 2-0 rapid vicryl or that or polyglactin, discolored the white polyglactin 2-0, that is the ideal suture material for all episiotomies. And how to detect a 3rd degree, 4th degree tear, how to detect a lone tear, and how to repair it, the 3A, 3B, 3C, all those details they will be teaching us. And
Thank you, ma'am. Thank you.
So for all our specialists, we will have world authorities talking to you soon.
Thank you,
after,
madam. Thank you.
Soon after we finished ultrasound, one round. And that we will be having that also. And Professor Sultan has agreed. I presented them to all the works that were done in the hub and spoke model, and they were very happy. And they said, we are happy with the work that you are doing in Orissa, and please tell us how we can help out. So probably in history, world authorities will be coming down to a state in India. And I also, when I gave the proposal in URPSS 2022, I said other states can follow it up. I think some work has been done. Okay, now we'll discuss poll questions. 89%.
Yes, madam. Madam, now discuss.
Yes.
Okay. So
Question number 1.
Question number 1. I think most of the participants has responded in a right fashion, and transabdominal scan cannot be done in empty bladder. The reason is,
Yes.
what we need to do is, by filling the bladder, we are dispelling all the bowel loops, which are gas filled above the uterus, and therefore and urine in the bladder is a perfect acoustic medium through which sound waves will travel 100%. And that is the reason we will be able to see the pelvic structures beautifully, and therefore we fill in the bladder. So this is the right answer, right response.
Would have been 100%. Why some people have answered 4? In spite of telling you the answer right at the outset, still some of them have been choosing.
Right.
Next question.
They have been shy to change it actually. So question number 2, the right response is the first one, that in a longitudinal scan, the cranial part of the uterus is seen. I think this image was beautifully shown by Dr. Pramodini, that the uterus, the fundus is seen to the left of the screen. It is to the left of the screen. That is patient's right is on the left side of the screen. So this is the correct response is the A, and I think 78%. 78%.
Sambit sir, what was the pre-poll percentage? Sambit, hello. Sambit sir, have you left? What was the pre-poll percentage in first question number 1 and 2?
Ambit Babu ଶୁଣି ପାରୁଛନ୍ତି?
ନଥିବେ ସାର୍।
ହଁ ହଁ.
No, what happened?
Okay, maybe he's not there. So anyhow, I think we will go to question number 3 now.
Okay.
And in a transverse scan, patient's right side is seen on which side? Patient's right side is seen in B is the right response. It is seen to the left of the screen. So that is the
93%.
93% have responded rightly. Always try to remember there is a marker on the probe, right? There is a marker on the probe and there is a marker on the screen. Now both should agree, you know, both should be, let us say, if the marker is on the on the left side of the screen, I have to move my rotate my transducer anti-clockwise. This is the basic fundamental principle that the marker on the probe and the marker on the screen should agree to each other. So then you will never make a mistake about left and right. No? So question number 3 is already done. Number 4, all are true regarding TVS except. We have already discussed that TVS, I already told that it can't go beyond 10 centimeters and therefore we cannot have a good overview. Any pathology which is beyond the pelvis, if it is lying in the abdomen, will be missed if we are doing only transvaginal scan. So the right response is 88%. They have responded right. Yeah. Sambit Babu, has he come back? Sambit Babu? Sambit Bhai, actually, I think he must, he's there, but I think he's there as present. Hello? Am I audible?
Yes, sir.
Yeah, okay. Now question number 5. Question number 5 is transverse diameter of the uterus is best taken at. I think this is also Dr. Pramodini has shown a beautiful slide and also told that the widest part of the uterus, you know, the widest part in a transverse view, we don't include ovary, we don't include any other structure. It is the widest part of the fundus, including that view of the endometrium. And again, please try to remember, never ever measure endometrial thickness in transverse view. Never. It is always in the sagittal view that we will measure true endometrial thickness. Please remember that. Yeah. So
Sagittal view and in the upper corpus.
right.
Not the uppermost, but between the uppermost and mid corpus, where the endometrium is thickest.
Right. So A is the right response. A is the right response, and it is what is the here at the level where both ovary, this is wrong. At the level of maximum endometrial thickness. Okay.
Question number 6.
At the widest part, it is taken at the. So question number 6 is about measurement of cervical length, which is not true. Now, the method of choice to measure cervical length is always, it is always a transvaginal view. It is a transvaginal probe. So transabdominal scan is not a good choice to measure cervical length. So 86% have responded right.
Correctly.
Yeah. I think most of the participants are brilliant now. They have been doing we have hitting almost more above 75, 80, 90% now. And gynec scan of they have got a lot of information also. Yeah. Now regarding the measurement of the uterine length, which is true, about the uterine length is measured trace method is more correct than measuring in straight line, because while if you are measuring in straight line, there will be intra-observer variability. Let us say you are placing a distance, cursor, and I am placing a distance cursor. So it will be more of intra-observer. If you scan and I scan. So even inter-observer variability there. If you are measuring it for the second time, your measurement may not be correct. So trace is the ideal one, because you are tracing right from the fundus inside the endometrial cavity right up to the cervical canal. So trace method is the 47% responded right.
I think they didn't understand. Trace method was shown by Pramodini, that if you measure right from the fundus till the cervix, it will be shorter than, especially when the uterus is anteverted or retroverted. You have to follow the endometrium right from the fundus through the endometrium to the external os. It was beautifully demonstrated by Pramodini. I don't think this confusion should have been there. The B should have been chosen by majority. I think they came later, after it was discussed. Or Narottam, you could answer color. Trace method color. Okay, sir, next question. So you have to trace the uterus.
Straight line le मजा कराओ.
Straight line ta bhul.
Straight line ta आपनकर machine रे थिबो, trace थिबो, देखिबे. आपनकर machine रे थिबो निश्चय.
Madam,
trace टिके अधिका आसीओ दले length रा अधिका आसीओ trace रे.
नहीं length आसोनी.
hello.
नहीं fundus रो आरंभ करिवो, जो curve जोटी पुनी हे जिवो से पर्यंत मापिबो. पुनी जोटी curve
Smita madam wants to say something.
point नो मापिबो. पुनी जोटी curve हे तो मापिबो. तीनटा चारटा दरकार पड़ी पारे according to the curvature of the uterus. तक सब
If
add
we can, okay.
कौन
If we
Pramodini?
can,
Yes, Pramodini.
madam, if you can take two lengths at the angulation of the body and cervix and add, it is not correct.
Yes, it depends. Supposing instead of the uterus was more curved than that, you may have to take 2 or 3 distances.
Okay.
2 is enough. 2 is enough.
2,
Depends on the
Depends on the angulation. If the cervix is more angulated, you have to do twice. If the fundus is more and anteverted or anteflex, then you have to take thrice, 3 times.
Especially if it is a acutely retroverted uterus, retroverted gravid uterus, it is completely, the fundus is below the level of the cervix. In that case, you have to take the trace method. Otherwise, from fundus to cervix will be a very short distance.
Yeah, anteflex or
Okay.
retroflex.
Okay, madam. Thank you.
So question number 8. Question number 8. Which is correct in ultrasound of a postmenopausal woman? I think all the options given here, all of the above are correct, because it gets pathology and has to be investigated. The Dr. Pramodini has beautifully shown this. Any cystic structure, however small, in a postmenopausal ovary is abnormal, because it could point to some kind of pathology. White spots in the periphery of the uterus are explained by this calcification in the arcuate artery was very well demonstrated by Dr. Pramodini, and therefore all of the above, and 90% of the participants have responded right.
Very good.
Question number 9. Which of the following statement is correct? Which of the following statement is correct? Now,
Incorrect.
Incorrect. Okay. Yeah, it is incorrect. So, 93.
93% have answered correctly. Very good. Because you can't see the normal fallopian.
Yeah, we cannot see the
There's
fallopian
inside
tube. Yeah, all the tube. For example, this goes for everything. Like normal ureters, we are not seeing. Normal fallopian tubes, we will not see unless they are filled with some kind of fluid or there is a mass somewhere. Then hydrosalpinx can be seen. Normal fallopian tubes can be normally they are not seen in all cases. She had already put one slide showing that when there is a fluid in the pouch of Douglas, she showed us she demarcated the fimbriated end of the fallopian tube, which was visible. So 93% have responded perfectly. Now we are coming to the last question here. For understanding ultrasound findings using standardized terminology, which of the following are used? Again, all of these things is correct, and 72% of participants have responded right. Now let me share you what is IOTA. IOTA is International Ovarian Tumor Analysis Group. Now this group was actually created by three people. One was from Lille Valentin. I think madam knows her. Shama madam knows Lille Valentin. Then there is a Timmerman from Belgium, and Tom Born is from UK. And international, this is for endometriosis. There is another group. IDEA is another group. You know, and MUSA is regarding myometrial pathology. So they have created a standardized protocol about measurements and definitions also. So this is very important, and we will share all these papers on our virtual group. You can go to the Google and take that paper and print it out and read it actually. So all of these are very classical documents by a lot of experts, whereby we will reach an expert level. This is because why we make a standard procedure. Standard procedure is, I am sitting in Titlagarh. I do a measurement in a very systematic way, and my patient goes to Sanjay Rai in Bhubaneswar or Dr. Pramodini in Cuttack. Then she will agree because I have measured it in a very standardized way. So we are all speaking the same language. That is why all the standards are set. All the measurements are done in a very standardized plane. And also the information and the definition, why we call this a solid tissue, why we call this is a cystic tissue, what kind of, so all the definitions and also the measurements are perfectly standardized so that we all speak the same language, and any other person other than me can interpret the same thing because they will understand my language. So this is what is the,
most importantly, you will be able to detect by those rules whether a tumor is malignant or not malignant. So that is very important. Even in early stages, you can suspect a malignancy, and you can refer this for to higher up, and you can know what are the tests you have to do. But at least the whole thing, you can suspect and catch a malignancy even very early.
I think
are very important. And deep infiltrative endometriosis, the idea is also extremely important because it requires higher end surgery and higher end treatment. And you have to be sent up to higher centers. And even endometriosis, international endometriosis, that also is extremely important. And the MUSA group also is again important. So these little bit of basics of all these groups are important because you can catch problems early, and especially malignancies you can catch early, and this will result in saving of lives of these women.
And there is a next model which I think Dr. Ranjana Bhandari and Indira Palo and also Dr. Mala Sibal is also coming to our meeting. They will talk about one next model software. That software will easily allow you to calculate what kind. Even you can say, okay, this is the kind of tumor you are dealing with. So you
Some machines, I think the GE machine has the simple descriptors, simple rules inbuilt in the software. So that
But next model is for sale. Next model is for sale. We can purchase from either Google Pay or Apple devices, Apple Store. So it is for sale. It is not free, but simple descriptors and these are available on machines. But next model is a risk calculator.
Simple rules are easy to remember, and we can know what is the percentage of malignancy is there in a particular type of display of the tumor. What are the different descriptions are there, whether unilocular, multilocular, one solid areas, papillary projections. All these will be taught, will be trained by your eyes, and you will be able to suspect which are the ones you have to refer immediately without any delay, so that patient can get a good treatment. Okay.
And those who are interested, let me tell you, share with you, Dr. Mala Sibal has written a book, and also it is an atlas where all the gynecological pathologies are, the pictures are beautifully, she has demonstrated, giving the criteria also. So let us see when she comes, we will share the picture of that book, her book also.
So Ashok sir could not join today.
Oh, I think he must be busy. He just came from Greece. He came from Greece only on 5th he has come. So maybe after coming back, all his patients are possibly there is an overload with him.
Okay.
He came from Greece.
From the participants. Any last questions before we end the exams? Before the end the poll, sorry. Okay. Shall we end? Saroj sir, Saroj Panigrai sir asleni.
Saroj babu ashanti.
आमे आपन को हम स्पेशलिस्ट को पे गुड न्यूज रखचंदी सरोज सर, सरोज पाणिग्राही सर, प्लीज.
He is taking something. He is busy eating something. Saroj babu.
Panegrahi sir.
He is eating something.
But he has helped us so much. He has fine-tuned all the proposals. Saroj sir, can you give us any good news? Saroj sir. Hello.
He is hungry.
Saroj sir, can you hear us? Saroj sir. Please join. Unmute yourself. Unmute. Any good news? Any good news for our specialists?
5 o'clock hunger. 5 o'clock hunger.
Saroj sir, any good news for our specialists? As the MD.
मैडम आमे जो पेरिनियल इंजुरी आउ एपिसिटोमी ऊपर जो प्लानिंग करिसे तामे ऑलरेडी फाइल हैज बीन पुट अप विथ एमडी एनएचएम. मैडम आज ही बदे ता ऊपर साइन करिवे कि कोन करिवे से जणे देबे मैडम को देई के आछि मु. आ गुटे मैडम पर गुटे कंसर्न थिला मैडम, हमर जो सीएलएमसी कॉम्प्रिहेंसिव लैक्टेटिक मैनेजमेंट सेंटर जो खोली छि कैपिटल हॉस्पिटल ता एससी रे खोलिबो. कि ह्यूमन हमर जो मिल्क बैंक
संजय सर अछंती कैपिटल हॉस्पिटल रे.
हां ता ऊपर मैडम जे ओजी स्पेशलिस्ट माने जेतो फास्ट इंटरेक्शन करंती मा और छुआ संगरे से माने सजेस्ट करंती, तेनु ता ऊपर टिके फोकस करिकि काउंसलिंग करिवे बोली मैडम कहिसंती.
हमें तापे गोटे सेशन कर दी परिबा.
हां मैडम ता ऊपर गोटे सेशन कर देला ऊपर
लीना दास
परम जो फार्मूला मिल्क जो दिया होची अन्य जो यूज करचंती जो माने खीर होनी जानि पारु नाहंती से मानन को पई मैडम इट इज गोल्डन अपॉर्चुनिटी नेक्स्ट पीआईपी रे 9टा 18टा जिल्ला रे मध्ये एलएमयू लैक्टेटिंग मैनेजमेंट सेंटर भी मैडम आमे खोलिया को जाउचो तो तेणु ता ऊपर सब ओजी स्पेशलिस्ट मान को ओरिएंट करिबा बे मैडम कहिसंती आपनक थ्रू आपण टिके मैडम कहि देले दैट विल बी इफेक्टिव हबो आ सेटा मध्ये बहुत लोकंकर बेनिफिट हबो मैडम ता ऊपर गोटे छोटिया सेशन नेक्स्ट शुक्रवार मैडम आमे कर देले बेटर हबो
हां हम गोटे करि देबा आपण रेडी करंतु
आज्ञा
लीना मैडम प्रेजेंट करिवे ना के
हां लीना मैडम कर देबे लीना मैडम कर देले बढ़िया मैडम से मैडम तो सब जानि छथि से ऊपर
हम कांटेक्ट करूची तो
एससीबी में
अपार्ट फ्रॉम गायनी अल्ट्रासाउंड हमें गोटे एडिशनल
10 मिनिट ऊपर खाली गोटे ओरिएंटेशन कर देबे जे तार कोन यूज आ ओजी स्पेशलिस्ट सर मैडम मान जो अछंती से केमिति लोकन को ओरिएंट करिवे ता ऊपर टिके जणाई देबे ड्यूरिंग जतरा डिलीवरी से अटेंड करछंती कि जहा भी करछंती ता ऊपर टिके ताको सेंसिटाइज करेबे लोक
exactly what they're supposed to do for developing increasing these milk banks which are lifesavers for the babies.
Yes ma'am.
Because I know there was one very sick mother who couldn't feed her baby. She was in the labor room and she couldn't come. She was for 3-4 days outside, and we found that in the postnatal ward, other mothers were feeding this baby in turns. So this is the kind of concept that they were afraid, they were so sympathetic for the baby who couldn't feed from its own mother. The other mothers who were there in the postnatal ward, they were feeding this baby in turns. They were giving their milk to this particular baby who survived. It's such a human side of our treatment, our management, and the milk bank is specifically meant for these babies who cannot receive their mother's milk, so that they can receive it from the bank. I think it's a very, very important concept again for reducing our IMR. Na kono?
ना मैडम
ये हमर एक्चुअली एब्रॉड में कोन होय
रनिंग प्रॉपर्ली बहुत बढ़िया मैडम रनिंग होची कैपिटल हॉस्पिटल रे हम आ तक आउट के स्ट्रेंथनिंग करी हमें कैपिटल हॉस्पिटल रे एमसीएच भी गोटे मिल्क किचन करिवा पई भी प्रपोजल देइथलु मैडम को मैडम बिचरा राजी हिचंती आ एससीबी रे तो मैडम हमें प्लानिंग करछु विद इन नेक्स्ट 1 मंथ हमें तक ऑपरेशनल करेबु जेमति भी तो तण मैडम एटा गोटे बहुत भलो इंटरवेंशन ता ऊपर निहाते हमें फोकस करिवा मैडम
मैडम मोर
the next session Leena madam and you also be there Saroj sir. So
yes ma'am
सरोज बाबू आपण आमर एक्चुअली आई डू नॉट नो वेदर वी हैव हियर और नॉट अब्रॉड व्हाट हैपेंस दे हैव गॉट ए मिल्क बैंक मदर्स मिल्क बैंक ता माने जो मारो एक्सेस मिल्क होची से माने ताकू से मिल्क ता काढी करी सेठी दियंती से माने you know they donate actually mother's milk जो मानकर एक्सेस हो थाए
again
and storage facilities are there and according to the demand, like they have a person who has demanded and it is given to them. I do not know whether this amor ethi achi ki nahi mu jani nahi
madam same jinso sir same jinso jota ki madam ame ite sir ଦି ପ୍ରକାର ଜିନିଷ କରୁଛୁ ଗୋଟେ ହଉଛି MOM ଆଉ ଗୋଟେ ହଉଛି DHM MOM माने होची मदर्स ओन मिल्क जो माने की प्रॉब्लम रे रहउचंती से माने एक्सप्रेस करि पारु नांती से माने को एक्सप्रेस करि कि हमें दउछु ता संगे संगे हमें डोनर ह्यूमन मिल्क मध्ये दउछु जोटा कि हमें पास्चराइज करी सब प्रकार टेस्ट करी पूरा प्योर मिल्क जोटा कि कोनोसी प्रकार हार्म करिवो नाही छुआ को हमें भी सेम जिंस सर आपण जहा सुनिचंती एटा भी सेम जिंस इट इज वन ऑफ इट्स काइंड ओडिसा रे फर्स्ट हमें करिचो कैपिटल हॉस्पिटल रे वर्तमान सेकंड सीएलएमसी वी आर प्लानिंग टू ओपन एट एससीबी कटक आ 18टा एलएमयू हमें 18टा जिल्ला रे करिवो इंक्लूडिंग एमकेसीजी भीमसा अन्य अन्य मेडिकल कॉलेज मानकर मध्ये हमें टारगेट ताको रखछु
व्हाट अबाउट डिस्ट्रिक्ट हेडक्वार्टर्स
यस सर यस मैम हम 18टा को प्लानिंग करछु 18टा भितर 3टा मेडिकल कॉलेज अछि आ 15टा डिस्ट्रिक्ट हेडक्वार्टर हॉस्पिटल अछि
तो जदी कैपिटल हॉस्पिटल हलानी आरजीएच रे भी करिया उचित
आरजीएच रे मैडम हम एलएमयू प्लान करछु लैक्टेटिंग मैनेजमेंट यूनिट प्लान करछु सीएलएमसी दीटा गोटे एससीबी गोटे कैपिटल हॉस्पिटल
सीएलएमसी रा फुल फॉर्म कोन
कॉम्प्रिहेंसिव लैक्टेशन मैनेजमेंट सेंटर एलएमयू होची लैक्टेशन मैनेजमेंट यूनिट
थैंक यू वेरी मच so in the next session I'll contact Leena so that she makes a small presentation and you also be there
Yes, ma'am.
We were talking about other checklists in the mentors list, like
mentor list भी madam already madam को दे दीजिए.
the
Madam
UNICEF
has
should
told,
prepare the
madam has
checklist.
told कि Editech, DFW and Mina Swam our UNICEF ର madam जो अछंती आमे तीन जण बसिकी will work upon that. आमे आज ही जाई थांतो किंतु अन्य कामरे सब व्यस्त रहितबा तो सोमवार दिन आमे बसियो परि प्लान करिसु. फर्स्ट स्टेप आपनकर जो गोटे प्रपोजल थिला मैडम इनविटेशन फ्रॉम एमडी एनएचएम टू द नेशनल एंड इंटरनेशनल एक्सपर्ट्स सेटा ऑलरेडी मु आज पुट अप कर देछि मैडम पाखरे. जदि मैडम साइन कर दोचंती आज ही मु इश्यू करे देबी. बाकी मैडम तो छुट्टी रे जाउचंती, छुट्टी पीरियड रे भी मैडम कहिचंती आपण माने बसी कि जहा डिसीजन नेबे आई एम ओके विथ दैट, तार किछ असुविधा नाही. तेणु मैडम आमे डीएफडब्ल्यू संगे आगो प्राइमरीली कथा ही जाऊ, तांकर मतामत जानि सारिबा परे देन प्रपोजल वाइज आमे गोटे परे गोटे मैडम आमे काम करिबा. गोटे गोटे प्रपोजल को नै कि आमे तार टोटल कोन करा जिबा कथा कोन नै आमे काम करिबा. ता संगे संगे 16 और 17 अप्रैल जो वर्कशॉप हेतिला सेठी जो पॉलिसी रिकमेंडेशन देइथिले एक्सपर्ट्स माने सेटा भी मु मैडम को देइछि. ता ऊपर भी मैडम कहिसंती आपण डिस्कशन करंतो, डिस्कशन करी कि मोर जहा इंटरवेंशंस दरकार आपण मते कहिले आई विल बी देयर, नो प्रॉब्लम. एति दूर आमे काली कथा हेछु.
Thank you very much.
Thank you.
Okay, shall we end the meeting?
Yeah,
Yes, ma'am.
thank you,
Thank you.
Pramodini madam, for your beautiful
Thank you very
presentation.
much, Pramodini.
It
And
was very good and very
pictures which you showed
informative.
also will be very useful for the following sessions,
Right.
which again I
Dr. Pramodini has laid the foundation for others, So she talked of the very preliminary basic thing, where other experts will now go on adding onto each topic. Right. Thank you so much for being the founder of the gynec module.
I think Sambit, shall we end the meeting?
हाँ, हमें end कर दो मैडम, end कर दियो.
Thank you very much, everybody.
नमस्कार मैडम, नमस्कार.
Sambit, shall we end the meeting?